the introduction there. Yes, continue. Thanks for the introduction into the topic there, Gaurav. So upfront, I want to acknowledge Dr. Mohan Radhakrishna for his feedback and guidance in creating the presentation, and also recommending several of the articles that are informing the presentation. Today, I'm going to cover the evolution in the literature and the management of knee osteoarthritis with interventional options, predominantly focusing on knee RF or radiofrequency. I have no conflicts of interest to declare. So I'm hoping after today's talk, you'll have a refreshed appreciation for the burden of knee osteoarthritis pain, both in terms of prevalence and costs to our healthcare system. I'll be reviewing available guidelines on the management of osteoarthritis pain, which you can use in discussion with your patients. We will have a refresher on anatomical knowledge of knee joint innervation, so you can all debate your colleagues at lunchtime with fervor. We will talk about the literature in depth. So after this, you should be really able to wow your friends over beers. And finally, I will review what new knee radiofrequency treatment options there are, and we're going to critically appraise the knee radiofrequency literature together. And I'm going to be referring it to RF for the rest of this talk. So to start, prevalence studies have found an age-standardized knee osteoarthritis occurs in 3.7% of people. The prevalence is almost twice as high in females, and the prevalence peaks at the age of 50, which for me was something I don't think I was really aware of, as it strikes me that this seems to be quite a young age to be affected with knee osteoarthritis. And also from a management point of view, I can't think that if it was me at age 50 that I would want a knee replacement if I had significant knee osteoarthritis pain at the age of 50, given that the average knee prosthetic lasts 8 to 10 years. And obviously most of us would probably plan on living several decades beyond that if possible, and repeated knee replacements would not really be desirable. Quite profound is the estimate of the medical costs of knee osteoarthritis, with up to 2.5% of average national GDP going towards knee osteoarthritis, and most of this is accounted for by surgery. When we look at the WOMAC classification, which is a measure of function, high-income countries report 74% of cases as mild, moderate being about 24%, and severe as 1%. And finally, the burden of knee osteoarthritis is dominantly carried by those over the age of 65, with a third of people in this age category suffering from knee osteoarthritis. So defining osteoarthritis is important to understand, especially once we start talking about recruitment of patients into the studies we're looking at today. Radiologically, knee osteoarthritis is defined using a Kellgren-Lawrence grading system, and studies have generally only included patients with a grade of KL2 to 4. This is predominantly defined by the presence of osteophytes. Now, as already discussed in Dr. Christopher Maher's presentation in the fall, the KL grading scale is likely to be a significant underestimation of the true prevalence of pain and disability burden in knee osteoarthritis. So traditionally, osteoarthritis has been thought of as a wear and tear disease, but this hypothesis in recent years is thought to fall short. For one thing, joints are not affected symmetrically, which if it was pure wear and tear, they theoretically should be. And while BMI is considered a risk factor, BMI does not reliably correlate with prevalence. So the current theory is that the pro-inflammatory state associated with obesity is more likely a part of the etiology. And that would also explain why obesity is correlated with osteoarthritis in the hands, which obviously have no role in weight bearing. It would also explain why exercise is considered the #1 non-pharmacological intervention and not necessarily something that would make osteoarthritis worse. Other factors involved in pathophysiology include aging, previous injury, genetic predisposition, gender, and anatomical factors such as joint shape. So that's where things like dysplasia come into play. Posture and alignment. So valgus patients are more prone to developing this. So I did want to spend a little bit of time talking about the neuroplastic changes in knee osteoarthritis. knee is a joint especially prone to sensitization. And based on QST results and studies, sensitization is quite prominent in osteoarthritis. What's interesting is that up to 50% of patients with severe osteoarthritis damage are asymptomatic, whereas 10% of patients with moderate to severe OA have normal x-rays. Or sorry, knee pain have normal x-rays. Sorry, that didn't make sense. So patients with KL2 scores, and remember, that's one of the milder grades, who have severe pain have been found to suffer with severe sensitization. And therefore, I think we really need to consider knee osteoarthritis not just as an articular disease, but also a neuropathic one. And in fact, one study found that 70% of knee osteoarthritis patients have at least one somatosensory abnormality. Okay, so moving on to what's out there in terms of management. So from a family medicine perspective, the peer group has established excellent work in the entry-level stuff. So there's a systematic review of systematic reviews that put into visual terms what we all probably already know. So exercise is the most beneficial treatment that we can convince any patient to undertake. And the green faces are showing who improves with treatment compared to yellow faces improve compared to controls. And then the red faces are the ones that do not improve with the treatment. So after exercise, there's a fair cohort who do well with intra-articular steroids, then duloxetine, and then NSAIDs after that. So this sort of fits with what we theorize about inflammation and neuropathic pain as part of the pathophysiology. Now, all of these other pharmacological treatments like opioids, glucosamine, chondroitin, and viscosupplementation do not do as well. Acetaminophen is really not useful at all. And when you look at the data from publicly funded trials, they're looking at multiple like glucosamine, chondroitin, and viscosupplementation. They really have not much convincing benefit. So there's a systematic review that came out in 2014 that covers the basics that we just talked about, but also talks about things like walking aids, thermal modalities, and then items that have mixed consensus, such as heel wedges, knee braces, or acupuncture. And with regard to some of the more interesting interventional options, at that time, only the AAOS had thus far mentioned the possibility of consideration for intra-articular platelet-rich plasma injections, or PRP for short, in its 2013 guidelines. But until more recently, no other interventions were really mentioned at all. So then in 2019, the American College of Rheumatology published its updated guidelines on the management of osteoarthritis. And we can see for the first time mentioned is radiofrequency ablation, and it's conditionally recommended. So there's a column here for knee and then conditionally recommended there. And so this is a really important step up in terms of expanding our algorithm of managing knee osteoarthritis management from drugs, intra-articular steroids, and then straight to surgery. So it's opening up less drastic options in between. So the treatment space in which we now find ourselves in between steroids and surgery is starting to consider things like stem cell injections, which, by the way, I encourage anyone who was not present at our interventional rounds in the fall with an interest in stem cells to listen to Dr. Christopher Mara's talk that is archived on the Alan Edwards website. You'll get to hear all about his love for beautiful mesenchymal stem cells. And in this realm is also PRP, prolotherapy, which hasn't found consistent evidence yet, but likely will eventually find its place. And then what we'll be focusing on today is neuromodulation procedures such as radiofrequency ablation. And even surgically, they are now exploring less drastic procedures such as high tibial osteotomies, which have been shown to delay progression to surgery in greater than 74% of patients. So given that the peak prevalence is at the age of 50 and total knee arthroplasties have a shelf life, it does make sense for the patient and for the healthcare system to consider less drastic treatment options that previously have not been considered, like curing knee osteoarthritis with magnesium. Now, this slide is here just for Sydney. Sydney, I am perfectly capable of making fun of myself. I don't need you to do that for me anymore. Okay, so I'd like to present a case. I have an 87-year-old woman who lives alone, who had sudden onset of severe right knee pain about 1.5 years ago. It started after a routine walk and never went away. It was always quite severe. She received intra-articular steroids without benefit. And then in June of 2020, she was offered a total knee arthroplasty. And unfortunately, post-operatively, she had absolutely zero resolution of her knee pain, and it went on to progressively impair her function and impair sleep due to severe pain. Pharmacological interventions were tried, such as an SNRI, opioids, and nabilone, all of which consistently caused her side effects, predominantly dizziness. And given that she lives alone with impaired mobility, she's now a high falls risk. When I first saw her, we actually discontinued all of these in light of this and lack of any perceived benefit. We tried topical capsaicin, but this was only helpful for short periods of up to 30 minutes. And topical lidocaine was less helpful than capsaicin, but anything fancier topically than that was limited due to her budget. So at this point, we offered her a genicular nerve block with the possibility of a subsequent RF. Okay, so diving into knee RF, I include this slide here so that all of you will know fluoroscopically what the conventional fluoro targets are in most of the studies concerning knee RF. So I present first a summary of the initial landmark trial in knee RF published in 2011 by Choi and colleagues. So this study was a randomized controlled trial with a sham lesion in 38 patients who had a KL score of 2 to 4. Exclusions are listed here. Needle placement was done under fluoro, and only patients who had greater than 50% pain relief for greater than 24 hours with 2 mils of 2% lidocaine were offered RF. The 24-hour definition of block success was one of the criticisms of this study in subsequent literature, because as we all know, the local anesthetic effect of lidocaine is not 24 hours. They performed a sensory stim of less than 0.6 volts and a negative motor stim of 2 volts, used a 22 gauge RF needle with a 10 millimeter active tip. Target temperature was 70 degrees for 90 seconds with 1 lesion per site. These guys measured both pain and functional outcomes using an Oxford knee score, and results showed that 59% of the RF group versus 0% of controls achieved greater than 50% pain control at 12 weeks. And it should be said that this study, despite some flaws, does remain one of the better RCTs in the literature. A subsequent study done by Ayana Coney, sorry for the Italians out there, sought to look at long-term results beyond 12 weeks, and this was published in 2017. So they recruited 31 patients prospectively through retrospective chart reviews who had greater than 80% relief after diagnostic blocks of 1 mil of bupivacaine. Sensory stim was performed to a threshold of 0.15 volts, and absence of motor stim, which was not defined. In this study, the target temperature was 60 degrees for 120 seconds. Now, this study, in my opinion, was far less well done for many reasons, and we could start nitpicking at the target temperature alone. But study flaws were numerous in that they did not describe their statistical analysis. They had major loss to follow-up at 6 months, which most studies in this field have not had on NERF. But despite this, they did report similar results at 3 months, at which time 61% of patients continued to have meaningful pain relief, which they don't really define in the study. But important to take away from both studies thus far is that no major adverse effects were reported. Mild adverse effects of transient numbness were reported, but otherwise no weakness, neuralgia, or paresthesias. So in here, they reported their results by patient, and although average pain relief was 64%, you can see that there were many patients that really had no relief or poor relief. I guess minimal response would be the better term altogether. Okay, so this study in the same year, 2017, out of Spain, by Cudsey, Sinclair, and colleagues, compared knee RF versus blocks with steroids to the conventional RF targets after knee arthroplasty. So this was the first study specifically to look at knee pain, knee RF in a postoperative knee population. It was a randomized controlled trial of 36 patients. Exclusions are listed there. And interestingly, no diagnostic blocks were performed. They used a standard sensory stim of 0.5 volts and a motor stim of 2 volts with a similar needle as the previous studies. Target temperature was 80 degrees for 90 seconds, and again, 1 lesion per site. The steroid group received 2 mils of bupivacaine, 0.25%, and 0.5 mils of triamcinolone. They found similar results in pain and function at 12 months follow-up, with a slight trend toward better in RF, but it wasn't statistically significant. So, and here are the outcomes reported with standard deviations of the pain scores, the Oxford Knee Score, Knee Society Score, and the 36-item short form survey that looks at overall functioning. And I think it makes sense that neither of these interventions, RF or steroid blocks, are likely to improve objective measures of knee function, such as degrees of flexion or extension. So I'm not sure that the KSS score means much in this context compared to a study looking at a regenerative intervention treatment like stem cells or PRP in theory. However, if pain is significantly less, then obviously that could have a meaningful impact on subjective function, in which the SF36 and parts of the OKS score are. So that's like, sleep or ability to perform ADLs. This next article on our list by Kim and Friends in 2018 was interesting to me because it was the first study I'd come across in the body of literature that looked at ultrasound technique. Granted, they did not look at RF, but they did test the age-old question of whether adding a steroid to a local block outperformed local anesthetic alone at the conventional RF target sites. So 48 patients in a double-blind randomized controlled trial were split into a group receiving Lido and another group receiving Lido plus triamcinolone, and they followed patients to 8 weeks. There was no benefit to adding steroids at 8 weeks follow-up in either pain or function. And it kind of occurred in the discussion part of the paper that many studies that do find benefits seem to be conducted in the post-operative period. So I think it's a slightly different population. Now, this was an article that was on our list that is included, and it's interesting for a few reasons. So these guys reported using chemical neurolysis of the conventional RF targets in 4 patients who had been refractory to RF or were not candidates for RF. They used 6% phenol in 3 patients and alcohol 98% in 1, and they tagged it with contrast. So in other words, they observed the contrast spread under live fluoro to decide when to stop injecting. Phenol volume was 0.75 to 2 mils. No major adverse events were reported in this small case series, and the patients had 5 to 12 months of profound pain relief and improved function. The authors suggested that this should be considered a viable option in patients who do not respond to RF, which at this time frame in the literature, 2018, was about 25%. And also they pointed out that this is low cost, it's easy, and it's a safe procedure in anticoagulated patients. And what the authors also pointed out, which has been the subject of debate in this literature, is that this method accounts for the anatomical variation of the genicular nerves, which we're going to discuss shortly. So for reference, you can see that all of these patients had pain lasting for at least 5 years. and they all had at least 80% or greater pain relief. Okay, so innervation, something that I puzzle through with my own patients, trying to work through what pain generators might be. So this is the classic sort of diagram in which I would typically try to refer to when teasing this out. But what is important to realize is that this sensory map is of the cutaneous distribution. It doesn't necessarily correlate with the joint or structure in question below. And then this chart begins to delineate which muscles are innervated by which nerves, but you can see that this chart does not really tell us which nerves are innervating a joint. And you know, unlike the picture, the nerves do not stop mid-thigh. So this has been criticized as a weak spot in previous studies in the literature, that it's not actually agreed upon which nerves innervate which part of the knee joint. So a couple of really well done anatomical studies help to shed some light on this. Now, this excellent graphic was generated by our colleagues out of Toronto who dissected 15 cadavers and then plotted the course of the genicular nerves onto a skeletal model, which gives us a stronger sense of the variability of the genicular nerves, and then helps us to clinically correlate knee pain with innervation. So this study led the authors to recommend consideration for a bipolar or even tripolar approach of the supromedial region of the knee, given the size of the region the nerve to the vastus medius may traverse. And this is published in the Ultrasound for Interventional Pain Management textbook as well, by Peng et al. In 2020. So another cadaveric study was published in 2019 of 21 limbs with no previous limb surgery or pathology. Interestingly, they found that a total of 5 constant genicular nerves with accurate landmarks could be targeted instead of just the 3 that have been published thus far in previous studies. So what this study adds is that the innervation to the supralateral region of the knee is somewhat controversial. And it seems that whether this area is dominantly innervated by the femoral or the sciatic nerve originally is somewhat disputed. And I think this is important because it does affect decision-making of what procedures could be offered if a supralateral genicular nerve RF fails in a patient that has dominant supralateral pain. So this article implied that the sciatic nerve was the origin compared to the Tranidal article, implying the femoral nerve origin to the supralateral aspect of the knee, coming from the vastus lateralis dominantly. So this is a little bit above my ability as a non-anatomist, but it's still interesting. It has interesting clinical implications. So by around 2016, enough studies had come out that our colleague in Toronto, Anuj Bhatia and company had written a narrative review. They looked at 13 studies, of which only 2 were RCTs, and they included several techniques. So not just conventional RF, but also PRF, which is pulsed radiofrequency. And there was also work done on intra-articular PRF. They reviewed the use of prognostic blocks and found that blocks did not seem to have any bearing on the overall success rate of RF. Not surprisingly, they reported findings to be of low evidence and suggested the need for more robust methodology. For one thing, sample sizes have been small. And overall, the studies have been consistent in finding, despite these limitations, they're consistent in finding greater than 50% pain relief in the majority of patients with various follow-up periods, despite different temperature targets, lesion times, and taking into consideration anatomical variation. And of course, this group, they pose the question of whether this could be performed using ultrasound guidance. And then also it would be interesting to know in future if this is useful in prolonging time to surgery. Okay, so this study, having said that there needs to be something on ultrasound, here we go. So in 2017, Santana et al. Published a study on 25 patients with a KL grade of 3 to 4. They used no diagnostic blocks. Under ultrasound guidance, they used a 23 gauge RF needle with a 5 millimeter active tip. There's a sensory stim of less than 0.6 volts and motor stim of 1.2 volts. They lesion for 90 seconds to 80 degrees at the conventional RF target sites. Follow-up at 6 months was similar to previous studies, with 64% of patients having greater than 50% pain relief. And at 12 months, 32% still continued to have greater than 50% pain relief. They also looked at patient satisfaction outcomes, and 84% of all patients reported good or very good satisfaction with their results. Now, this was one of the articles I included for your reading pleasure because it was well done and it was one of the few looking at ultrasound. So this was the other study that I'd put on your reading list because it really showed the sum of randomized controlled trials to date, and I thought concisely emphasized a lot of the points of today's presentation. So it was published in 2020. This systematic review examined 33 articles, of which 13 were RCTs, and the vast majority, 24, have been published in the last 3 years alone. The total group of patients together included 1,512, of which 1,189 received RF, and then 323 received conservative or non-interventional management. Controls were offered intra-articular steroids or intra-articular opioids, intra-articular hyaluronic acid, PRP, intra-articular ozone, and intra-articular erythropoietin. RCTs were found to have moderate to high quality, and prognostic blocks were only used in a third of the studies. In comparative studies, 65% versus 19% in controls of patients obtained greater than 50% relief. So again, very positive in support of this procedure. And all 33 studies indicated significant relief in RF patients from baseline to the final follow-up, the longest of which was 12 months. Very importantly, 27 of 28 studies reported significant improvement in WOMAC scores, which is that one of those functional outcome measures. No major adverse effects were reported, and all 3 RF modalities showed benefits. So conventional RF, cooled RF, and pulsed RF. One of the studies was a randomized controlled trial comparing RF directly between fluoro and ultrasound, and they showed equivalent benefit in patients. Still, a flaw of this particular review is that, well, it's not of the review, it's of the body of literature, is that there's actually still quite a fair amount of heterogeneity in the studies that are included. So if we look at this lit review in 2020 that looked at only fluoro-guided genicular nerve RF of just RCTs, Tate et al. Reported that diagnostic blocks have no predictive value on the outcomes of NERF. The trials ranged from 59 to 74% of patients having greater than 50% pain relief at 6 months. These guys, they also talked a little bit about predictors of failure, which was interesting. So patients who had longer history of knee pain, current smoking, KL score of 4, and performance of bilateral genicular nerve RF. These trials again reported no serious adverse effects, but the authors did comment on case reports of pes anserine tendon injury, septic arthritis, and third-degree burns. So finally, a super cool article that came out in December of 2020 with Koshi et al., one of our maritime colleagues. These guys, they endeavored to perform fluoro-guided genicular nerve RF of 7 sites, targeting 6 nerves. However, there is only 4 needle insertion sites. They just repositioned the needle within a couple of locations to obtain the 7 total sites for lesioning. They used a trident needle, which is a 3-timed needle that the manufacturer reports can attain a lesion size of 9 by 7 by 7. These guys also did not use diagnostic blocks, and their results were outstanding. 91% of patients obtained greater than 50% pain relief at 6 months, and 82% of patients obtained greater than 80% pain relief at 6 months. So, I mean, given that it was published in the fall, it'll be really interesting to see what the results are by 1 year. And obviously, this is just a small case series of just 11 patients, but this is just really exciting to think about where NERF is headed. I just would like to shout out to Jordy for sharing this article with me. Okay, so naturally, I'm sure a lot of you are interested in the landmarking. So this figure shows the fluoroscopic views of the 7 sites. The body of the paper also does a nice job of describing the landmarking for anyone who wishes to consider this approach for their knee patients. And now a lot of us, of course, may be more interested in performing this procedure under ultrasound, and it will be interesting to see if we can attain similar success rates. This study just came out in December of 2020. Again, thanks to Jordy for sharing this with me last minute. But unfortunately, I was unable to access it in 3 universities until one of the interlibrary systems actually just sent it to my inbox this afternoon. So I haven't had a chance to review more than the abstract, but it's a cadaveric study by the same people who did the anatomical discussion earlier, who are testing whether the 5 genicular nerve sites they identified in their study could be reliably targeted under ultrasound. So they placed dye under ultrasound to 10 limbs and then dissected them to confirm accurate placement. And the black dot that they placed was in direct contact with a nerve site at worst 7 out of 10 times, with the worst mean distance at the recurrent fibular nerve of 2.4 millimeters plus or minus 4.5 millimeters. And that certainly would be captured with a 3-timed needle. So this group is so far the only to suggest the recurrent fibular nerve as a target, as traditionally in most studies, the infralateral region of the knee has been considered too high risk a target for RF because of the motor component of the common peroneal nerve. And also that there's no bony backstop against which to place the RF needle. But in these guys, in their anatomical study in 2019, they talked about a safe sensory target on the tibia, that would theoretically be safe because you could even do it under landmark according to them, and it's located between Gerdy's tubercle and the tibial tuberosity. So just a comment about the recurrent fibular nerve, or the RFN. Obviously, this study only confirms that ultrasound is accurate and capable of targeting these nerves. So the bigger question will be when it's conducted in a group of live patients, if they can obtain the same results as Koshy et al. And that's kind of also going to test the therapeutic difference in the anatomical assumptions made between those 2 major anatomical studies in cadavers that I discussed before. Because the one study talks about, 7 different contributors, or 6 genicular nerve being contributors, and these guys talk about 5, but there is a subtle difference between the sites. Okay, so to follow through with my case, before I did all of this background review on NERF, I had offered my patient genicular nerve blocks in December, which I probably would no longer bother doing given what we've talked about today. The patient had sustained relief to the medial aspect of the knee by 7 weeks follow-up. However, unfortunately, she had no relief to the superlateral aspect of her knee, which in her case was also the most painful area. So as a result, I decided to move farther up the leg and see if we could achieve results with ephemeral PRF. However, given the conflict in the anatomical studies, if it doesn't work, it may be because the sciatic nerve is possibly involved. The patient had her femoral PRF on February the 16th, so I don't have details yet on whether this was effective. But if I was to repeat the whole assessment from scratch, I might consider subsequently that such a patient could go straight to NERF, and I would consider adding these other sites that have been recently published, especially if more confirmatory literature comes out showing its reliability and reproducibility in terms of results. So research, it would be great to stratify populations. So For example, severe OA patients that are non-surgical candidates, or mild OA patients with severe neuropathic pain, post-surgical knee pain patients, which, by the way, like that is anywhere in the literature from 15 to 33% of post-knee surgeries that continue to have significant knee pain, with the average landing around 20%. So this is a patient population that otherwise doesn't really seem to have many options. Post-traumatic knee pain would be interesting as well. It would be obviously good to have larger studies. I think the role of prognostic blocks, it seems like it's on its way out, but it would be good to just kind of really determine that, especially once we land on a protocol that seems to be very effective. It would be really neat to see if pulsed RF of the larger nerves head-to-head with TRF of the smaller localized nerves has a difference. And then initial studies of ultrasound versus fluoro technique, they didn't show any difference in successive outcomes. So that would be something just to confirm, because ultrasound is obviously less radiation, easier to access for many clinicians. The type of RF lesion could be examined head-to-head between conventional cooled and bipolar RF. Although with the use of a 3-tined needle, this could easily take the place of a bipolar lesion, which does require placing 2 needles. And then finally, a new procedure which is being studied at McGill actually is genicular arterial ablation compared to genicular nerve RF. So overall, in summary, the knee RF does seem to be showing consistent signs of outperforming intra-articular steroids and other conservative therapies. And quite frankly, like if we had meds that showed greater than 50% pain reduction in the majority of patients, it would be prescribed to everyone with knee OA. It does seem that the standardization of technique and anatomical targets is likely to improve, further improve success rate. Diagnostic blocks seem to be of questionable use in predicting outcomes. So in the interest of saving time and resources, it would be reasonable to go directly to RF. Further research with ultrasound and different knee populations should help us select correct patients for optimal chance of success. And finally, this does seem a viable alternative to surgery in some, and possibly prolonged time to surgery in others, or at the very least, better managed pain while waiting for surgery. And with that, these are my references. Not included is the study, the ultrasound study on the 5 targets that I just received today. So I will send that out to anyone who's interested, because I did not have a chance to look at the pictures and the ultrasound images for the placement for their knee RF. So I'll include that. So I'll take any questions now, or at least try to answer them to the best of my ability.